So let's start again. So we will first start discussing what is glucocentric and what is adipocentric approach, and how diabetes and obesity are interlinked. What is adiposopathy? What are evidences available in adipocentric approach? What the guideline says before concluding. So glucocentric approach is the traditional way of managing the diabetes, in which we control the diabetes, we achieve the glucose targets, how much it should be controlled with highly efficacious medicines. Screen is not visible. वहाँ पे नहीं चल रही है. Diabetes and the obesity. As the BMI increases, the risk of diabetes increases proportionately, more in the women than in the men, and more than 80% of patients with diabetes are found to have obesity. So, how obesity leads to diabetes? We all know that obesity is a state of chronic mild inflammation because of release of adipokines by the adipose tissue. It leads to insulin resistance. Besides this, there is release of free fatty acids in the circulation by the adipose tissue that lead to lipotoxicity, intracellular changes, mitochondrial dysfunction, and that further increase the insulin resistance. So, obesity not only increase the insulin resistance, but also because of lipotoxicity, it causes beta cell decompensation that leads to diabetes. Besides this, obese patients have some limitation in the physical activity, and also there are psychosomatic factors that leads to increased risk of type 2 diabetes. In the patients who develop diabetes after a long term obesity, if there is neuropathy that limits the mobility, and it further increase the risk of obesity. Even some anti-diabetic medication cause weight gain, and the hypoglycemia leads to increased stimulation of food intake. All this leads to obesity. So it is a vicious circle that needs to be broken if we want to really manage the patient well. So increased adiposity not only leads to increased risk of diabetes, but also it is associated with increased risk of other complications like NAFLD, macrovascular complications, CAD, CHF. As obesity increases the sympathetic activity and RAS activity, it leads to hypertension and associated complications. Besides the metabolic complications, there are mechanical complications also like obstructive sleep apnea, increased risk of urinary incontinence, osteoarthritis, and not only that, obesity increases the risk of cancers because of chronic inflammatory state. So whether it is the weight that is causing the problems? No, it is the fat distribution and fat adipocyte dysfunction. So abnormal fat distribution and abnormal fat function is the main culprit, and because we know fat also is protective for our body. Fat doesn't means that it is harmful, but the fat which is it is a fat distribution that matters. Subcutaneous fat has limited reserve, so when this reserve exceeds, the adipocyte hypertrophy occur. When the adipocyte hypertrophy occur, it exceeds the adipocyte size exceeds its vascular supply. It leads to generation of a state of hypoxia in adipocytes. that cause reactive oxygen increased generation of reactive oxygen species, and which lead to adipocyte dysfunction. Besides this, the location of fat distribution is important. If the fat is located in the intramuscular region, in the epicardial region, in the perivascular region, it not only cause systemic complication, but it cause local complication to endothelial dysfunction and increased risk of atherosclerosis. So, visceral fat which is directly drains into the liver, so cause more metabolic complications, while subcutaneous fat is thermogenic and is protective for body. So it is the adiposopathy, not only the adiposity, that is the main problem. So weight loss is beneficial across the disease continuum. So if even in the prevention of metabolic syndrome, even in the prevention of pre-diabetes, even in the prevention of progression of pre-diabetes to diabetes, weight loss matters at every step. So it is important to start the weight loss before the complication even starts. So not only it leads to improvement in the metabolic complications, but also to the improvement of other comorbidities and the mechanical complications associated with the obesity. So managing the weight is the upstream approach in managing the patient who has developed diabetes or who is at the risk of developing diabetes. So treating the pathology is the right approach rather than just controlling the blood glucose level. So do we have evidences in supporting these statements? Yes, because in the Darkwing study, Finnish study and diabetes prevention trial has clearly shown that if there is 50%, there is decrease in the risk of development of diabetes in the patient who has pre-diabetes if there is weight reduction. Even it has been seen that even 1 kg weight loss decrease the risk of progression of pre-diabetes to diabetes by 16%. So not only in the state of pre-diabetes, if the patient developed diabetes, there were fascinating results in the seen when the patient have undergone bariatric surgery. It was seen that 80% patient with diabetes achieve remission if they undergo diabetes bariatric surgery. So more is the weight loss, more is the better is the glycemic control. So restrictive procedures have less chances of remission, while the malabsorptive procedure have more than 90% chances of remission if the patient undergo bariatric surgery and the patient has diabetes. So not only the diabetes risk is reduced, but the cardiovascular risk factor are also decreased with the achievement of weight loss. So even 5 to 10% of weight loss is better for the cardiovascular health. So what about the diet and lifestyle? The direct trial has clearly shown that if the patient lose 5 to 10 kg of weight, then 50% of the patient achieve remission from diabetes. And what is the remission? Remission is HbA1c level less than 6.5% for at least 6 months without medication. So remission of diabetes can be achieved with the weight loss. What about the patient who have normal weight and diabetes? That is the clean diabetic patient. Yes, the trials, that is Retune study, has shown that even in the patients who have BMI less than 27, if the patient achieves the weight loss, then there is definite improvement in the glycemic control, and even the patient achieves remission. And it is it is the personal fat threshold. Every patient has different fat threshold. If the adipocytes increase that fat from that fat threshold, the patient has metabolic complications. So weight loss is even beneficial in the patient who have normal BMI if they have diabetes. So in the traditional trials like UKPDS Accord Advanced VADT, who have clearly shown that the microvascular complication decreased with the glucose control, but they didn't show cardiovascular improvement. Why? Why the cardiovascular improvement was not seen even with the intensive glucose control? Because they have seen the weight gain. So even if there is glucose control, but mortality will not decrease if we didn't achieve the weight loss. So the newer medication who have shown that there is weight loss, then there is improvement in the CV outcomes, as clearly seen in the trials with the SGLT2 and GLP-1 inhibitors. So effect of weight loss is proportionate to the decrease in the comorbidity. More is the weight loss, more is the benefit. 5 to 10%, if we want to achieve just the glucose control, then 5 to 10% weight loss is beneficial. But if the patient achieves more 10 to 15% weight reduction, then the mechanical complication also decreases. Like there is decrease in the obstructive sleep apnea, GERD, in urinary incontinence. And if the patient achieves more than 15% of its baseline weight, then there is a good chance of diabetes remission, and there is decrease in the CV mortality and even heart failure with a preserved ejection fraction. So we know we have medicines, a lot of medicines to treat the diabetes, but some are weight neutral, some cause weight gain, and some cause weight lose. So our preference should be to choose the medicine wisely. Even the guideline says that the first line of treatment should be, first goal of treatment should be the weight management in the patient with diabetes, so that we can achieve the remission of diabetes, and the choice of medication depend upon their efficacy of weight loss. And intermediate weight loss. So to conclude, the adipocentric approach not only can prevent the diabetes, but it can achieve the diabetes remission also. It can halt the cardiovascular complication with additional advantage of improving the comorbidities like hypertension, dyslipidemia, fatty liver disease, obstructive sleep apnea, and other mechanical complications. So both approaches are necessary. It is not that glucose control is not necessary, but along with the glucose control, we should also focus on the weight reduction, so that we can achieve comprehensive, we can provide comprehensive patient care. Thanks a lot.